Thank you so much, Katie. That was really excellent. Um, we're going to change gears from sort of more highly scientific to um, much more down to the heart of what we do. And I'm super excited to have Dr. Charlotte Marcus here from University of Pennsylvania. Dr. Marcus and I were in residency together. She was starting, I was just finishing residency at NYU. And so now here you are in Alaska for your first time. And so it's going to speak to us about a really important topic that is when it's time to stop treatment and making the transition to best supportive care.
Thanks, everybody. Really excited to be here to speak on this important topic. Um, by no means is this the answer. This is a very individual conversation, and there are a lot of things to consider with each patient. But I hope to just talk about some general guidelines and present sort of a framework for initiating the discussion. So this is a sort of graphical depiction of the journey from diagnosis of cancer to treatment choices. The circle represents just the changes that one may go through in a treatment regimen. And then at some point, exiting the circle to what we call survivorship, which is when treatment ends and you may be thinking about what to do next and how to get over some of the side effects from treatment. And then disease progression. I altered this diagram a bit. If you look at the end of the diagram, there's points where you're in survivorship, but then you may have to re-enter the circle of treatment. There's points where the disease has progressed, certainly, and you may re-enter the circle. But really, the question that we're talking about today is when to stop. And I'll share with you just in the last 2 months, I have encountered this in a lot of patients. Really, three stand out. One woman was diagnosed with stage 4 ovarian cancer 5 years ago, has been through, 5 or 6 lines of chemotherapy. And she came and talked to me about, whether to consider stopping treatment or continuing. And it's funny because whenever she comes in, she already has the answer. She's almost just including me, just a heads up, if you will, as to what we should do next. But she decided to stop treatment and enter hospice. And at that point was completely comfortable with her decision. She talked to her family, she talked to me, she talked to her other oncologist, and had really arrived at a point where we say she was at peace with the decision. I had another patient, a younger woman with a uterine sarcoma, who recurred within a month after finishing her chemotherapy with a big mass that could not be removed. And I told her that sarcomas are hard to treat. They're generally not responsive to chemotherapy, especially since she'd recurred within a month after ending her previous chemotherapy. There was not a likelihood of anything else working. Not to mention, she was critically ill. She couldn't eat. She had a small bowel resection. And so I told her that we should not continue treatment. She was in the hospital for about a week. I spoke with her. I spoke with her family members. This is not something that we do alone. So I enrolled our, palliative care specialist. And ultimately, she and her family decided to leave the hospital to get a second opinion at another facility. She arrived there, they told her the same thing, and then she was at peace with the decision and decided to enroll on hospice. The third patient was a woman I treated for uterine cancer who did well for about a year and then recurred. But she was quite sick, couldn't eat, and I suspect had not been feeling well for months. You know, lo and behold, her daughter had just had a new baby. Another daughter was in school and very busy. And so she hadn't told them anything about what was happening for months. And so she was in the hospital for 2 weeks, at which point we were just trying to get her family comfortable with the information because the patient knew, but her family did not know. And so they were just in war mode, right, to try and figure out what to do with mom next. So those are just three very scenarios in the course of a couple of months. Um, when we talk about why people decide to continue treatment, it may be because the treatment is helping control symptoms. So for example, if they are having vaginal bleeding from a tumor, sometimes we will treat with radiation, or the chemotherapy may be helping in some way to address pain. Another common option is there's an experimental therapy, which they're a great candidate for because they have some molecular alteration, and there's a new treatment for that. Sometimes people just want to give it one more try because even though things haven't worked in the past, there may be something out there. So similar to my patient who left, our facility to seek another opinion about just what is out there that may help, and then to gain more time. And I would say, personally, this is a hard one to do because it is hard to watch somebody have side effects from a treatment that has little clinical benefit, but may give 1 month, 2 months for the patient to get used to it or for the family to get used to it. And likely to give the patient and the family time to adjust to the prognosis. But it is not our responsibility as healthcare providers or our role to decide what side effects people can endure, because lots of people are willing to endure significant side effects for just a little bit more time. So there's a study by Kondo et al. That looked at why people choose to end anti-cancer treatment. By far, the biggest reason is because of disease progression, about 50% of the time. 8% of the time, it's the patient's desire. 17% of the time, they're having side effects that are not manageable. And then about 20% of the time, it's due to something called their performance status, which I'll talk more about in a little bit. In general, these were not included in the study, but we know that after 2 or 3 lines of treatment for any solid tumor, there's less likely to be clinical benefit after then. Or the treatment may be cost prohibitive. A lot of the immunotherapies and other therapies that we have cost tens of thousands of dollars each time. And if they are not FDA approved, then it can be challenging to get that treatment covered, but it is possible. So performance status is one of the single biggest indicators of whether someone is going to be able to have a response from treatment and endure the side effects. So performance status, there are a couple of measures that we use. One of them that you may have heard of is the ECOG, right? So it's a very simple scale from 0 to 4, and 0 being you're fully functional. 4 may be that I think they word it as near death, and in between is how much you're able to do of your activities of daily living. And this can be simplified a lot of times, when we see people. Are they able to walk into the office visit, or were they fully functional before, but now they can't make it from the parking lot to the office without being in a wheelchair? And so these are some of the tests that we use. And you may not speak with it with your physician, but usually in the chart somewhere, the nurse or the doctor or somebody has assessed the performance score. So performance status. So as the performance status starts to decline, what this graph is showing is, so the purple line is what we call an ECOG 0, and the green line that's furthest is an ECOG 4. And you can see that as your performance status starts to decline, meaning you go from 0 to 4, the overall survival probability is much lower. So performance status can predict poor survival, it can predict reduced response, and it certainly can predict worsened toxicity to treatment. Now there are some challenges because many clinical trials will not allow patients to enroll unless your performance status is at least a 2. And so we don't know what happens to women from a clinical trial standpoint with a worsened performance status. And in general, there are few trials that compare treatment to best supportive care. Okay, there are not too many people who are signing up for that clinical trial, right? And so we don't know that information. There are some exceptions to this. If your performance status has nothing to do with chemotherapy or treatment, maybe you were injured or in a trauma, that doesn't count in terms of your eligibility for chemotherapy. You are at your baseline. And others are if you have, again, tumor where there's a good target, a treatment target, a molecular target, then we can sometimes use that despite the performance status. So you may have heard of Choosing Wisely guidelines, and these are things that were sort of rules based on research that are used to determine how we use our health resources effectively. And so one of the ASCO guidelines was the top 5 list of interventions that are costly, widely used, and really not supported by high level of clinical evidence. So one of the ASCO guidelines says, do not use cancer-directed therapy for patients with tumors who have a low performance status of 3 or 4, have no benefit from prior-based interventions. So this is similar to my patient who unfortunately recurred a month after ending her chemotherapy. Patients who are not eligible for a clinical trial, and patients who have no strong evidence supporting the clinical value of further anti-cancer treatment. But despite this, we know that it happens, right? Because we're human, yes? And so when we look at studies to determine how often people are getting treatment within the last month of life or the last 3 months of life, it's high. This was a retrospective database study of Medicare beneficiaries in Massachusetts and California. And you'll see here where I've circled in red the percentage of people who were getting chemotherapy in the last month of life was about 10%. In the last 3 months of life, 22%. And in the last 6 months of life, about 35%. There were really no differences between Massachusetts and California. And some of the reasons, the investigators looked at the reasons why chemotherapy was continued to this stage. It was used for tumors that are both responsive and less responsive to chemotherapy. It was used about 4 times as often in younger patients in their 60s and 70s versus those who were in their 80s. For the vast majority of patients, they were on treatment somewhere between 1 to 3 months. And chemotherapy near the end of life, this is really the important point, is really associated with worse outcomes. It's associated with shorter survival, more frequent hospital admissions, more frequent patient deaths in the hospital, and a late referral to palliative care. Another similar study looked at why chemotherapy may be continued near the end of life, what factors matter. So about 20% similarly received chemotherapy 30 days prior to their death. The patients who received chemotherapy were more likely male and healthier, so they had less comorbidities. They were younger again and had a chemosensitive tumor. They had a higher educational status generally in this study, and they were more likely to get chemo if this was at a large cancer center or for-profit clinic, or if there was an absence of palliative care services. So we just need to start the conversation. And how do we do that? It's best to start before women are critically ill, where there's decision-making on the part of the patient as well as the family, if that's important. And it has to be a shared process between the oncologist, usually a palliative care specialist if they're available, and again, friends and family, whoever is important to the woman. And we know that there are differences in survival based on whether patients decide for themselves to end cancer treatment or whether their family members do. So this was a retrospective chart review that divided patients into a self-decision group and a family decision group. So if your family is making the decisions, right, if our family is making the decisions, it's most likely because we're too sick to make the decision on our own. So there are about 100 patients who decided from themselves versus about 67. And the reason to stop treatment was generally the same regardless of who made the decision. About 70% of the time it was disease progression. So the median survival, interestingly, in the patients who decided from themselves was about 145 days versus those where the family had to make the decision, which was about 23 days. And again, it's most likely because the people who were not able to make the decision for themselves were really ill. I shared with you the one patient who hadn't told her daughters anything, and her daughters ultimately had to make the decision to end care or take her off a ventilator because she became too ill. And so that's unfortunate. It's hard for everybody in that scenario. Patients whose family made the decisions are more likely to die in the hospital than at home. So that's important if one has a strong preference about whether they'd like to be at home or in a hospital setting. What are some of the barriers? This was a study that looked at GYN patients. So when patients are considering to end treatment, there's denial. We all go through it. We may have unrealistic expectations. In general, if we start the conversation earlier, then the expectations are clearer. There may be family denial. There may be fear of physician abandonment or concern about giving up. And there's lots of controversy about the fight analogy that we use when we describe getting treatment for cancer. That works for a lot of people. Sometimes it doesn't, and sometimes it's a burden on the patient if deciding to end treatment means you've decided to stop fighting. That is not what it means, right? But that is one of the hazards of that analogy if we choose to use it. There's a sense of duty to your family and wishes. There's anger, certainly about questioning whether there are other treatments or other options or better hospitals to go to. There's hope, a belief in a miracle, which we should always have. There's health literacy. I think this is getting better. People have more of an understanding of palliative care and that it should be involved earlier in the course of treatment. If you're younger, if you have a strong religious background, if you have a cultural background, these may all be some barriers to starting the conversation. And certainly there are healthcare providers' barriers. It's very hard to deliver the news. There's fear of harm or of disappointing the patient and family. In some settings, we saw that in for-profit centers, there may be some financial benefit to including patients on clinical trials or academic incentives. Lack of training in palliative care or fragmentation of healthcare. For example, if you're in a rural environment where there is no palliative care available, or an institutional culture that doesn't permit these discussions ahead of time. So how do we start the conversation? If one is presented with a treatment, important things are, how long do I have to live if I have more treatment? We don't know. We're terrible at this, right? But there are data from trials that can help to give an estimate. What happens if I do not have more treatment? So what side effects are most likely to happen? Will the disease progress? What will my symptoms be, and how can we manage those symptoms? What is the goal of more treatment? Will the treatment stop or slow my cancer, or are we primarily trying to prevent difficult symptoms from developing? And what can I do to make my quality of life better is a really important one. The role of the healthcare provider is to share the diagnosis, the prognosis as early as possible. About 63% of the time it's shared with family, and about a 3% of the time it's shared with the patient only. And as much as possible, if the family, friends, you can identify those people and bring them into the discussion through an office visit, it can be helpful with help in care planning and decision-making. But we have to assess the intensity of the patient's relationship with the family. This is not something that everybody wants. Any cultural or geographic considerations, this is something that we can simply ask about because we don't always know, and it can be important for a lot of people. So that's, all I have to say. Again, it's certainly not something we have the answers to. But in general, the earlier we discuss it, I think we've seen from the studies that the outcomes are generally more favorable. Thank you.